My name is David Chrimes. I am a molecular biologist by training, and I have been working in the genomics testing of embryos since 2008, so 12 years now, and prior to that I was working in the genetic testing of children born with severe learning disability, dysmorphia and similar conditions, and also in the prenatal testing of abnormal scans. So very much approaching this from a human genome genetics testing perspective, and that will be the basis for the presentation today. So the presentation today is very much around how the psychological impacts of miscarriage and the physiological impacts of miscarriage, how miscarriage risk is very much correlated between the risk of aneuploidy and how this risk of aneuploidy increases with maternal age. And then we will be looking at the evidence for how PGT-A utilization for miscarriage reduction is possible across all age ranges of people undergoing IVF. So in a bit more detail, we will be looking at 4 key topics. Miscarriage and maternal age. So how is miscarriage and maternal age related? As I said, we will look at both the physiological and the psychological impact of miscarriage on patients. We will look at how PGT-A works, the theory behind PGT-A, and why that is important for reducing miscarriage risk. And also look at the evidence, as PGT-A has been out there now for many years. So we'll look at the evidence for how the utilization of PGT-A has actually fed through into a significant reduction in miscarriage risk for patients. So let's start off looking at miscarriage and maternal age. It has been known for many, many years that aneuploidy is one of the driving causes of miscarriage, and in this particular study up to 70% of miscarriage specimens, or product of conception as they're sometimes referred to, showed some form of cytogenetic abnormality. Now, the vast majority of these were autosomal trisomies, so your autosome are the chromosomes shared between both male and female people, chromosomes 1 to 22. We'll look at a few of those in a bit, but they accounted for significantly half, 60% of trisomies in these spontaneous abortions were across the autosome. Monosomy X was also quite common. Now, monosomy X is also known as Turner syndrome, and whilst Turner syndrome can result in a live birth, most of those we now know are mosaic, but nonetheless they are frequently found in spontaneous abortions. And polyploidy, where you have either one copy of the genome rather than 2 or 3 or more copies, was also responsible for a further 20% of those found to have some kind of cytogenetic abnormality. So every couple is at risk of having embryos which are aneuploid, but it is correlated to maternal age. So if we start off looking at the green data, the euploid, the true euploids, in the under 35s, it's around 50% of embryos available for testing. So these are embryos which have made it to day 5, day 6, blastocyst and trophectoderm biopsy. 50% of those that are remaining are euploid, and the remaining are either aneuploid or mosaic. By the time we come to 38 to 40, we're down to 1 in 3 embryos are truly euploid, and by the time we reach 41, 42, we're down to kind of 22%, or effectively 1 in 5 embryos being euploid. And we have this corresponding increase in aneuploidy rate with age, and that you would expect. If they're not euploid, there must be an increasing chance of aneuploidy. Yes, there is also the embryos which sit in the middle, the mosaic embryos. They're a mixture of both euploid and aneuploid cells, And we discussed the significance of those in another webinar, mosaicism and all you need to know. And if you have an interest in mosaicism, I really recommend you watch that webinar as well. But really what we're looking at today is the increase in aneuploidy with maternal age and the decrease in euploid with maternal age, and how that impacts miscarriage risk. So again, this has been known for many years, and this is not related to IVF. This is just a natural phenomenon that aneuploidy is largely related to maternal age. So as the maternal age increases, then your risk of miscarriage increases significantly, especially after you reach the age of 35 and onwards. And we know this, and it's been known for many years. And if we look at natural fertility, we know that the chances of having a successful child as maternal age increases rapidly declines. And this is being driven both the increase in miscarriage, but also the overall decrease in the potential of a live birth by an increase in the aneuploidy in these embryos and in these eggs. The most visible and well documented increase in aneuploidy in human embryos and human eggs is trisomy 21, Down syndrome. And we know that in the under 30s, your risk of having a Down syndrome affected child is about 1 in 800, 1 in 1,000. By the time you reach kind of 42, it's 1 in 4. So that's the most visible and well understood from a patient population aneuploidy of humans. Now, for today's webinar, then I have chosen the UK data, but it's replicated across the world, that the average maternal age of patients undergoing IVF is increasing. The average maternal age of first-time mothers is increasing across most populations as well. And so what we're seeing here is that over time, since 91 to 2017, there's been the steady increase in maternal age of patients undergoing IVF. And the result of that is that now over half the patients undergoing IVF are now over 35. So very much in this increased risk of miscarriage. So, what is the actual impact of miscarriage? And this can be split into two parts, the physiological and the psychological. So we'll start off looking at the physiological impact of miscarriage. So your risk of miscarriage increases with maternal age. This we have discussed, but it's estimated between 15 and 25% across all age ranges of recognised pregnancies end in miscarriage. Now they can be split out further, and in some cases we have this what's termed as a missed miscarriage. So this is where the baby has died or failed to develop properly, but as yet it hasn't been physically miscarried. And these tend to be detected on the early scans where there used to be a fetal heartbeat, there is no fetal heartbeat anymore. But basically the body is still as yet has not rejected this pregnancy. We then have incomplete miscarriage, where the body has started a miscarriage, but there is still some fetal tissue still remaining in the uterus. So the cervix is dilated, but it's failing to get rid of all that fetal tissue and placental tissue from the uterus. Now, in both these cases of missed miscarriage and incomplete miscarriage, the patient is faced with a difficult dilemma. There's the kind of managed approach where it's either drugs or perhaps surgical intervention, or there's the wait and see approach to see if the body can naturally resolve itself. Now this is a difficult choice for patients, and one which really puts them under a huge amount of stress and on how that they wish that to be managed. However that pregnancy or miscarriage is managed, there are potential complications, even if the miscarriage happens without any intervention whatsoever. So you can have excessive bleeding and hemorrhaging. So if that is occurring, it obviously causes the woman to lose a lot of blood and sometimes requiring blood transfusions or even invasive surgery to fix the hemorrhages. Around 3% of women will acquire some kind of infection directly related to the miscarriage. The trauma and the blood floating around inside, unfortunately, the woman's intrauterine cavity is an ideal breeding ground for bacteria, and this can cause an infection which is highly unpleasant for the lady. In some cases, as I said earlier, you may need surgery, the dilation and curettage surgery. Now, that is obviously an invasive procedure, requires an operation, and operations come with risks. And we then have Asherman syndrome, which can occur naturally, but is quite often seen after this D&C surgery. And some reports have it present at some form in up to 40% of patients who have to undergo D&C surgery. So again, there is huge complications potentials for miscarriage. There's also the psychological impact. So even if you can medically manage the miscarriage, then there is the trauma and the psychological trauma to the woman. So this study back in 2018 showed that up to 15% of women suffer severe depression, which can last up to 4 months post a miscarriage. And that grief, that depression, was comparable in nature to suffering the loss of a close relative or other types of grief reactions that we would consider in everyday walk of life as a bereavement. So this shows how mentally trying it is for these women if they undergo a miscarriage. So this was followed up and was published right at the end of 2019, and they have now found that it actually goes as far as being post-traumatic stress disorder in many women. So we have these women who have had a miscarriage and they're now experiencing high levels of post-traumatic stress and depression. And yes, it declines over time, but it can still be clinically important even 9 months after that miscarriage event. Now, if you're feeling that traumatized and depressed, you're not going to want to undergo another embryo transfer with the risks that you perceive that may have. So this whole depression and the potential management of these miscarriages can delay subsequent transfers, or indeed for some women stop them having another transfer at all. So we want to reduce miscarriage, and we can do this through PGT-A. So how does PGT-A work? What is the theory behind it, and how can it be used for miscarriage reduction? Well, PGT-A is there to assess the chromosomal health of an embryo prior to transfer. So check that embryo has, to the best of our knowledge, the correct number of chromosomes. By doing this, we can better inform transfer decisions and identify the embryos most likely to lead to a healthy pregnancy. This is, I should be clear, a screening test. It's not a diagnostic, and there are other reasons why an embryo may have failed to implant. But we are trying to get the most information we can to inform the best embryo transfer decisions possible. And by doing this, we improve the IVF outcomes. We help the women have a successful transfer and a successful live birth with the least complications possible. So this is really what PGT-A is there to do. So as I said, we were talking about the chromosomal health of the embryos. So a euploid embryo is an embryo which has the correct number of chromosomes, and this has been shown to have the highest likelihood of a successful pregnancy. So here on the left we have our normal chromosome complement. So chromosome numbers 1 to 22 are shared. They're the autosome chromosomes that are shared between males and females. And then if you're female, you have 2 copies of X. And if you're male, you have an X and a Y. So X and Y are the sex chromosomes, and you should have 2 of them. So overall, your embryo should have 23 pairs of chromosomes. If you have an aneuploid embryo, it means you don't have these complete set of 23 pairs. You either have one gained, or you have one missing, or maybe more. And we know that an aneuploid embryo may result in a failed implantation, so you don't get pregnant at all. If you do get pregnant, you have a much higher chance of miscarriage. And depending on that genetic abnormality, you may have a genetic disease. Now, as I showed earlier, aneuploidy is found in embryos of any patient age, but it has been shown to increase with maternal age. And what we've highlighted on the left here is a trisomy chromosome 10. So there has never been a reported live birth of a trisomy 10. So if we find an embryo with a trisomy 10, then we know that the chances of that leading to a successful live birth is incredibly low. And this is what PGT-A is there to do, is to find the embryos with the highest chance and screen out those with the lowest chance of a successful pregnancy. As many of you are aware, I'm sure, there are also these embryos which kind of live in the middle, the mosaic embryos. And these are embryos which have 2 or more cell lines, which some of them are euploid, some of the cells are euploid, some of them are aneuploid. Now, we do know, and there's increasing evidence, that these mosaic embryos will implant less, and that will depend on the level of mosaicism. They will miscarry more even if they do implant, but they can sometimes lead to a healthy live birth. So again, PGT-A, by stratifying the embryos into euploid, mosaic and aneuploid very accurately, can inform better IVF choices and help patients understand the risk associated with that embryo transfer. So if we were to utilize PGT-A and adopt it in our clinic for looking and screening the embryos, what evidence is there that this PGT-A utilization will actually reduce the miscarriage risk for my patients? So here we have a overview of the key randomized control trials, and I've gone all the way back to the Mastenbrook 2007 just because it still is raised by some people. But basically, for the later studies using the newer technology, using blastocysts particularly in multi-cell, what we have seen is, and this is highlighted by the arrows, as an increase in implantation rate, so IR, and a decrease, so the downward pointing arrow, in miscarriage rate. And this is really today what we're looking at is miscarriage rate. So almost all of these studies and randomized control trials have shown a decrease in miscarriage rate. All of those studies in and of themselves are quite small, so they did a meta-analysis, and again, those using the later technologies, array CGH, NGS and SNP technology, have again all shown an increase in implantation rate, but key to this talk is a decrease in miscarriage rate. So what we're seeing is per embryo transfer, a decrease in miscarriage rate, and that is really where PGT-A is shown to have one of the key benefits. Now, there's many discussions as to the value of observational data versus randomized control trials, and that's a whole different talk, but today I want to go through some of the observational study data that is out there And this particular paper was looking at the advanced maternal age patient, average age of 38. And what they found over their study, which was done over 3 years, 2016 to 2019, was, it was 2016, 2017, 2018, published in 2019. And what they found is that their implantation rate was very high, between 80 and 86%. Their live birth rate per embryo transfer, very high, 60 to 73%. But really today, again, their clinical miscarriage rate was below 10%. Remember, these are in patients above 38 years of age on average. So to have a miscarriage rate below 10% is stunning. And the other thing that they highlighted is that this miscarriage was not affected by the embryo morphology. It was the euploid aneuploid that was driving this score for them. So if you find the euploid, put it back ahead of the morphological scores. This was another observational study, and what they did is they enrolled patients and they tested the embryos, and they only put back those that were euploid via single embryo transfer. And what they found is, irrespective of the patient age, pretty much, if you found a euploid embryo, then you had a very high implantation rate, much higher than without testing. And again, their clinical pregnancy rate was also very, very high. So you had an implantation event and a sustained pregnancy or a clinical pregnancy rate very much higher than without testing. And this again shows a low miscarriage rate if that embryo was shown to be truly euploid prior to transfer. And this was another observational data from a group in the US who looked over their data from 2014 to 2018, and they found many positives to PGT-A, but again, for the sake of today's talk, we'll look at the miscarriage rate. And in their control group, it was 13% across all age ranges. So this covers every single patient that came into their clinic. 13%, that's still low, but by doing PGT-A, they could reduce it to 4.4%. So only 4.4% of their embryo transfers resulted in miscarriage. That is huge and very good news for patients. They know their miscarriage risk from a true euploid is very low. Now, if we look at a clinical trial, this was one published end of 2018. This was looking purely at polar bodies. So this was taking the polar bodies from the oocyte to find out whether, by screening out the eggs that were likely to be aneuploid, they could improve IVF outcomes. And what they found is, just looking at the maternal contribution, so the egg contribution, they could halve their miscarriage rate without affecting the live birth rate per cycle started. So they were managed to achieve the same live birth rate per cycle started for the over 35. This was an older patient group, and they could get that with a reduced miscarriage rate and a reduced number of transfers. So women were subjected to fewer transfers and fewer miscarriages, and still maintaining the same live birth rate per cycle started by undergoing PGT-A. This was an earlier clinical trial done on high prognosis patients under 35 years of age. And again, they found that a background miscarriage rate of untested of 9.1%, very good, but these are high prognosis patients. But by doing PGT-A, that could be reduced to 2.6%. Again, a significant benefit for women in utilizing PGT-A to really reduce the miscarriage risk. This was at the time the largest retrospective cohort study that had been carried out. So it was 97,000 non-PGT-A cycles and 9,000, well, getting on for 10,000 PGT cycles. And for those undergoing PGT-A, so specifically aneuploid screening, they found that they had a decreased odds of miscarriage. So by doing PGT-A in this retrospective cohort study, yes, PGT-A reduced your risk of miscarriage. The side effect, if you will, was an increased odds of a live birth. So that's good, but they also had live birth multiple increase, and that is because in this study, even if they had PGT-A, they weren't driving for single embryo transfer, so there were many transfers which were actually 2 transfers of euploids. So the key though for this is that PGT-A was decreasing the odds of miscarriage. So the largest data set in the world is the data from the Society for Assisted Reproductive Technology in the US, and we have been taking a look at that data. So we have mined the data from 2016 through to 2014 through to 2016, which is the complete data, and the provisional data from up to the end of 2017. And if we look at the miscarriage rate, you will see that the miscarriage rate in the untested increases as we would expect, whereas with PGT-A, we flatten the curve. Now, it's important to note the size of this data set. So there were nearly 450,000 cycles in this data set, of which nearly 135,000 of those were PGT-A. So we're getting close to a population study here. We have multiple clinics, in fact the majority of clinics in the US submitting their data. We are covering all sorts of patient demographics, all sorts of clinic demographics, a huge number of variables collated into this data. And what this shows is your baseline miscarriage risk is around 12.5% in this data set for the high prognosis under 35s. Even in the under 35s, there's a slight reduction in miscarriage risk with PGT-A, but again, once we hit above the 35 ages, we're really seeing the increase, the uptick in miscarriage risk in the untested. By the time we reach 38 to 40, it's 25%. So 1 in 4 pregnancies will end in miscarriage. If we do it with PGT-A, it's 13%. Massive reduction, half the risk basically, compared to non-tested. And by the time you reach 41, 42, then your miscarriage risk is very high in untested, but remains low if you do the testing. So this again is showing across whole patient demographics, multiple clinics, the power of PGT-A to reduce miscarriage risk. So what this is driving is an increased live birth per embryo transferred. Ultimately, when we undergo an IVF cycle, the outcome we wish for the patients is a live birth, clearly. Now, we want to achieve that in the fewer transfers as possible, and this is what PGT-A will give us. So PGT-A is basically maintaining around a 50% live birth rate per embryo transfer. Now, if we don't do PGT-A and we just transfer the embryos sequentially, by the time we reach 38 to 40, only 1 in 6 transfers will result in a live birth. So you're going through potentially 3 to 4 extra transfers compared to doing a euploid transfer just to get that live birth. Even at 35 to 37, you're going to have statistically 4 transfers or double the number of transfers to get a live birth compared to doing PGT. So by reducing the miscarriage and reducing the number of embryo transfers required for a live birth, what we're now seeing when we look at such large data is actually a live birth per retrieval increasing if couples undergo PGT-A. And that is really starting to show significance in the above 35 age range. And this is almost certainly due to the avoidance of unnecessary transfers and the avoidance of the trauma of miscarriages, and making sure these patients get the best embryos as early as possible to increase their chances of a live birth with the fewest transfers and the fewest miscarriages and the fewest medical and psychological impact of that miscarriage. There is an also benefit in reducing preterm deliveries. Now, if you have PGT-A, you are more confident in doing a single embryo transfer. You know that that embryo that you are transferring is euploid with a high chance of success. You're avoiding the double, triple embryo transfers, and we know that twins, particularly in older patients, have a much higher risk to the mother and of a preterm delivery. And this is where we start to see another benefit of testing the embryos and making sure we only transfer the highest quality embryos. We are also reducing the preterm deliveries and the complications associated with preterm deliveries. So I'd just like to finish up with a summary of this talk. So we know that miscarriage is highly traumatic for many women. And what we haven't really talked about today, and it hasn't been studied so much, is it is also traumatic for men. Miscarriage is most often caused by chromosomal aneuploidy. That has been shown through many studies looking at the product of conception and miscarriage testing. Increasingly and repeatedly, PGT-A has been shown to mitigate the age-related miscarriage risk. So here is a test, here is a technology that is there. So here is a test, here is a technology that is there, available and ready to help minimize this traumatic experience for women of miscarriage. And so by utilizing PGT-A, we have the power to reduce the physical and emotional trauma of miscarriage, and thereby increasing the chances of a successful live birth per cycle started for these patients.